I know that you have exam tomorrow. What's nothing in my hand? Okay. So I'm not sure if you have time to even open the slides from the previous week. It's okay, I know that, but you need to study. It has a lot of details. So today, inshallah, we will continue with the remaining part of the respiratory system. So let's start by reviewing a little bit the two different parts of the respiratory system. Last week we classified the respiratory system into two parts. Anatomically, upper and lower, but this is not our point. Then we classified according to the function into conducting portion and respiratory portion. And last time we covered most of the conducting portion. Okay, what is the function of the conducting portion generally? Conditioning. Okay, and what is the meaning of the word conditioning?
Humidifying, cleaning, filtering.
Yeah, three functions. Yeah, that's it. So it's warming, humidifying, and filtering. Okay, so we stopped there in the trachea. Can any of you remind me with the layers of the trachea? We have 4 layers. You remember? This is very important because we will continue based on this. The first layer from inside is
Mucosa.
then under the mucosa we have submucosa, then we have cartilage, which is C shape if you remember. Then we have adventitia. Good? Just keep this in your mind. You need this. Okay, then when the trachea is finished at the level of T5, what happened? It will bifurcate. Okay, and then it will give 2 bronchi. Both of them are extrapulmonary, but we still outside the lung, and you don't have esophagus behind the bronchi, right? Do we need the C-shaped hyaline cartilage?
No.
So we will remove it.
No. It will be different.
We will keep it,
Remodeled.
but full circle. So we have the full circle of hyaline cartilage, but not 100% complete circle. Okay. Then we will enter inside the lung. First, before we start this, let's go to know the structure of the lung. So how many lungs we have? We have 2 lungs. They are a pair of sponge air-filled space, okay? And I want to know the loops and the tubules and segments. This structure you need to know to make the bronchial division easy. Okay, so we have two lungs. On the left side, how many loops we have? 2. As you see, we have 2 loops. Okay, and then in the right lung, how many loops we have?
3.
We have 3. Then each loop will divide into segments. Okay, in the left one, we have 8 segments. On the right one, we have 10 segments. Good? Then each segment will divide into lobules. Can you stop talking, please? So we have loop, then the loop divide into segments, and then the segments divide into lobules. Good? Clear? Okay, so let's divide the bronchi based on this division. So the first division happened outside the lung, which is called the primary bronchi. Then we will supply the loop. So we can name this bronchi what? Loopal bronchi. Then we will supply the segment. So we will name this what? Segmental bronchi. So we will supply after this the lobule. We will name this bronchiole. Bronchiole. So how many divisions we have? We have 1 outside the lung, 2 inside the lung as bronchi, then bronchiole. Let's give another name. So the one outside the lung, we name it primary. Then the lobar, we name it secondary. Then the segmental. So choose one of them, but you have to understand the difference. This is the same names, but some people prefer to say primary, secondary, tertiary. Some just divide lobar, segmental, lobular. This is easy. Okay? Is it clear? Okay, so on the left side, how many loops we have?
2.
How many bronchi we have? How many lobar bronchi we have? 2. On the left side, we have 3 lobar bronchi.
No,
So let's go to this slide again. Outside the lung, we have the primary bronchus. Then the primary bronchus, once enter inside the lung, will divide to supply each loop. And this name what? Lobar. On the left side, we have 2. Okay, so the primary it's outside, then enter the lung. Then the secondary, how many we have? We have 3 lobar. On right side, 2 lobars and the left side. Then we have after the secondary bronchus what? Tertiary, supplying what?
Segments.
Segments, exactly. So how many segments we have on the right side
10.
and on the left side?
Eight.
The same. So we have the same number. Then we have what? We have the bronchiole. Sorry, the lobule. So here we have a bronchiole supplying bronchiole, then respiratory bronchiole, then alveoli, and this part, all of this we name it lobule. This we call pulmonary lobule. And it's supplied by what? Again, lobule supplied by bronchiole. So this is the last one. So you need to know this division. Okay? And I think this is will be repeated again in the anatomy.
We already took it.
You ready? Okay.
But we
good.
took
So you
that
know this.
the left lung have 9 segments.
She said 8 or 9 because we
Okay.
to 10.
It depends on the book, by the way.
superior and inferior.
Yes, I know.
Okay. Histologically, is there any difference between all of this division?
Yes. I think the bronchiole because they lose the cartilage, right?
No. I'm talking about the bronchi now. So now we have primary bronchus, secondary bronchus, tertiary bronchus. Okay? Do you think all of them have the same layers?
Yeah, I believe so.
Yes, but
Yes, but. Okay? Do you think we have the same layer like the trachea?
No.
Do you
Okay,
think
we
we
have-
will add, we will remove?
Who's the soft area?
It's like
What is soft
remodeling.
area? Okay. So let's go to this picture. How many layers we have in the trachea?
4.
4. Mucosa, submucosa, cartilage, and? Okay. But do you see this layer? This is what? This is the mucosa, right?
Mhm.
Why it's up and down like this?
Increase surface area.
Because we have what? We have an extra layer which wasn't here before. So how the lumen will be up and down like this? Because we have something make smooth muscle. We have a layer of smooth muscle which is new. It wasn't there before. We don't have this layer in the trachea. So in the bronchi we have extra layer of muscle. So how many layers we have now? So in the bronchi, all of them we will keep it like this. So the inner layer is
Mucosa.
mucosa. What is the lining epithelium?
See the surface.
Exactly. Then we have under the epithelium?
Muscularis.
No.
Lamina propria.
Lamina propria. So both of them making what?
The mucosa.
The mucosa. Then under the mucosa we have? No.
No, the muscle.
We have the muscle layer. Then it's a smooth muscle. And we name this muscularis. Then we have what? Complete. As exactly if it's trachea. So we have submucosa, then we have cartilage, then we have
Adventitia.
adventitia.
so
But we don't have C-shaped hyaline cartilage here. How the cartilage appear? It's a hyaline cartilage, but it's like small pieces. And we name this irregular plates of hyaline cartilage. So we will add layer and we will cut the cartilage into small pieces. This is the difference between the trachea and the bronchi. Yes.
so rather than that, an elastic tissue separating the mucosa, submucosa, and the trachea, we have smooth muscle in there.
This is not, the elastic membrane is not,
Yeah.
you can make it like this. But the smooth muscle you can't forget because we have many problems in diseases, pathology later on, because of this smooth muscle. Become thickened, asthma. Okay, so this is simply what we have. We have the same structure, but the cartilage ring will not become ring anymore. It becomes small plates of hyaline cartilage, and we have an extra layer of smooth muscle. And by the way, you already mentioned whatever I want to say in the layer. We have the first layer is mucosa, epithelium, and lamina propria. I will not change anything. The same exactly like last time. Then, just to remember this. You remember this? What is this?
The bulb.
This is the bulb. What is the bulb?
Bronchi-associated
Bronchus
lymphatic.
associated lymphatic tissue. What is this? This is exactly like the lymphatic nodule of the spleen and lymph node, but it's in the bronchi. It can be in the trachea, it can be in the bronchus, it can be bronchiole. Whenever you find it, it will be bulbed. This is very common. You have to know it. But it has to make up like follicle, small follicle like this. Then we have the muscle layer, which is called muscularis. Then we have the submucosa. Do we have gland in the bronchi?
No.
Why? Yeah. We have which type of gland? Serum, because we will never change. You remember? What is the only one which is different?
The olfactory.
The olfactory, which has only serum. So the submucosa has also gland, it's of course loose connective tissue, and then the cartilage and the adventitia. Nothing special. Just add the smooth muscle and cut the cartilage in 2 layers. Good? People in the back can go wash your face and come back. Okay. Then what happened after this? We are done with the bronchi. No?
Bronchial.
We have another layer which is the bronchiole. Then the bronchi start to divide many times to reach to a very small tube around 1 millimeter in diameter or less, even less. And this we name it what? Bronchiole. Supplying which part of the lung? Lobule. Okay. Is it important clinically? Yes. When we have a surgery, a problem in one of the lung, we don't cut the whole lung. We just go by segments. So if tumor in certain part of the lung, we cut whatever segment we can remove because it's connected with one of the bronchi. Just close the bronchi and remove this part. We will not remove the whole lung because if we have cancer in one loop or one lobule. We just go by the anatomical structure. So here we have bronchiole. So after many divisions, we reach to what? Terminal bronchiole. What is the terminal bronchiole?
The end of the
The last part of what?
conducting.
Of the conducting portion. And then what happened after this?
Respiratory.
We have outpocketing from the wall. What's this? We have something protruding from the wall. This is what? Alveoli. So once we have this, so it becomes respiratory bronchiole. So as long as we don't have any protrusion from the wall, it's called terminal. Once we have here protrusion, we name this respiratory bronchiole. Clear? So the respiratory bronchiole is what? The first part of the respiratory portion. The terminal bronchiole is what? The last portion of the conducting portion. So the first part where we can have gas exchange is the respiratory bronchiole. Do you think the bronchiole, which is very, very, very narrow, 1 millimeter, has the same 5 layers like the bronchi? Biologic. Do you think?
No.
Do we have space for all of this?
No.
Do you think the epithelium will be pseudo-stratified, ciliated columnar epithelium with goblets? If it's the first few branches after the tertiary bronchi, it still have a little bit short pseudo-stratified columnar epithelium. But after some divisions, we can't. There is no enough space for this. So what do you think? I want to move from the pseudo-stratified columnar epithelium to become very, very thin epithelium in the alveoli.
Technically.
How I go from this to the very thin epithelium? It will not be all of a sudden. It has to be gradually. Try. So the first one, if I say that the first bronchiole is pseudo-stratified columnar epithelium, then what's next?
Cuboidal.
Sample what? Sample columnar. Do we have goblet cell? No, we still have little. It will not disappear all of a sudden. So we still have goblet cell. Then I want to make it shorter. What I will do? Something in the middle.
Cuboidal.
Sample cuboidal. Do we still have goblet cell? Yes. Very rare. But we have a new cell. A new cell. Called
Transitional.
what? Called club cell or Clara cell. Okay, so if the bronchiole is a little bit big, it will be pseudo-stratified. Then it will be simple columnar with goblet cell, and of course we still have cilia. Then it will become a little bit shorter, so it is cuboidal, and actually I don't like to say simple cuboidal because it still has cilia. But we have new cell, but it's written simple cuboidal, but it still has cilia. Okay, and then we have a new cell. It's very important cell, very important. You have to know it by heart. What is this? Clara cell. I don't like the word Clara. It's called club cell. This is the new name of this cell. Okay? Why I don't like? The Clara is the person who did experiments on human until he find this cell in the lung. This happened during the Second World War. So he used human as animal. And then I think in 2012, I think they start to cancel his name from the textbook, but still, sometimes if we just use the word club, the cell is not identified. So still they write it between parentheses, but I'm sure that soon they will remove the word club. So just it's club cell, okay? So here, how is the size of the bronchiole? It's around 1 millimeter. Just remember, it's very narrow, we don't have a lot of space. The large bronchiole still have some goblet cell, right? Do you think we need the gland in the submucosa?
No.
Why? Doctor in the back, what do you think? Do you need the submucosa in the bronchiole? Do we need the gland, the mucous gland?
Yes.
Why?
To,
Focus here.
their,
I'm not talking with you, I'm talking to the last one. Okay? So why? Why we don't want the mucus? It's very narrow. Just imagine having mucus in this very narrow space. What will happen? Exactly, it will block the airway. Okay, so do you think we need the cartilage? There is not enough space for this. It's very narrow. We can't put cartilage in the wall, so we are losing layers, right? It was 4 in the trachea, then become 5 in, then now in the bronchiole. How many layers you are expecting? 3. Why?
Remove the submucosa.
Remove the submucosa and the cartilage. So what is the layers of the bronchiole?
Mucosa, muscularis, adventitia.
Smooth muscle and adventitia. You have to make them side by side. Don't memorize them separately. Just add layer, remove 2 layers like this, and relate this with the function. So it will be a little bit easier. Okay, so in the bronchiole, how many layers we have? We have mucosa. What is the lining epithelium? It depends. If we have large bronchiole, it's in the next slide. If we have large bronchiole, which type of epithelium? If we have a little bit small one, simple columnar with goblet cell, a little bit. Then it becomes shorter. With sclerosis, don't forget the sclerosis. Then we will say the sclerosis in detail. Let's return back. So here we have the mucosa, we have the muscle, and we have the adventitia. We miss what? We don't have cartilage, we don't have gland. We have very few goblet cells, very few. Okay? We still have cilia, by the way, right? Can we lose a cilia now?
Yes.
Really? If you have goblet cells, you have mucus. How you will push it out?
But
As long as we have goblet cells, we have to have subcilia. Otherwise,
the mucus will just block everything.
exactly, the mucus will stay in its place or even go down to the lungs. Okay? So this is simply the bronchiole. Okay, so let's go to the Clara cell. What is this? It's a cell it's a cell present in where? In the bronchiole. And as the bronchiole gets smaller, the number increases. Good? Why we need this? You know the surfactant in the alveoli? We have the same, but in the bronchiole. So this is a cell which produces surfactant-like substance. So we need this? Yes, we need this, because the small bronchiole can collapse very easily with expiration. So we need something to decrease the surface area, or the surface tension, sorry. Okay? How it looks like, I think. Okay. So this cell, it has a dome shape, apex, like the upper part is a little bit rounded, or a little bit round like this. And they are producing protein. So if the cell producing protein, which organelles you should expect in this cell? Rough endoplasmic microprotein. Rough endoplasmic reticulum, why? Protein. Then Golgi. Then it will store whatever. Ribosome with rough endoplasmic reticulum. What else?
Lysosome.
Vesicles. Why? Because we are storing whatever we made. Then how this vesicle will be excreted? By exocytosis. Okay? So they will go leave the cell by exocytosis. Is it active transport or passive transport? It's an active transport. So this cell is a protein secreting cell. And you will find this description in the comment. It has rough endoplasmic reticulum, Golgi, vesicles, and also has some of the smooth endoplasmic reticulum. Good? Then, what is the function? It's very important. What is the function? It's making surface active agent. It's like surfactant. What is the nature of this? It's lipoprotein. Lipoprotein. Why we have lipoprotein? So protein, we have rough endoplasmic reticulum, Golgi, and vesicle. What about the fat? From the smooth endoplasmic reticulum. This is why we need both of them. Okay, and what is the function of this? Decrease the surface tension. In which part of the respiratory tract?
Bronchioles.
In the small bronchiole. Small bronchiole. Good? Then, is there any other function? Yes. It produces certain proteins called club cell number 16. This is a protein called like CC16. What is this? It's one of the biomarkers. Like we know that we have a problem in the lung if we found this in the blood, or sometimes in the alveolar fluid if we dig it. Okay? So this is one of the important functions, and it's progenitor cell. What is the meaning of the word progenitor cell? Stem cell. For which cells? The cells around it. So here we don't have the basal cell anymore. The club cell do the job. Okay? So this is like the new cell in the bronchiole. In this picture, you have to just highlight that as long as we have the goblet cells, we still have what? And then we need to see a little bit lower. Why? Just to make sure that we are in the safe area. Like if some of this go a little bit down, we still have some here to push it up. And what is the function?
The
What?
muscles.
Mucociliary escalator. Okay? And in the trachea, bronchi, bronchiole, it's pushing upward or downward.
Okay.
Why?
Because we want it out.
Because we want it in the throat, in the pharynx. Then it's either swallow, which is the most common. Then if we have a lot of secretion, it's coughing or sneezing. Good. So this is simply what we have in the conducting portion. So again, we have to write the trachea first, then compare it with the bronchi and the bronchiole. Any comment on the first part? It's very easy. Any question? Don't forget, the club cell is really important. You have to remember that, yeah, we have pneumocyte type 2 in the alveoli, but also we have club cell in the bronchiole. To do what? Produce not surfactant. Lipoprotein. It's a surfactant-like protein. Okay? And what is this? It's to reduce the surface tension in the bronchiole, in the smaller one.
The club cell is only in the respiratory bronchiole.
No,
Or
it's
just the
also
very
in the,
small.
very small ones, starting from the terminal. Okay?
And then afterwards, all the respiratory have it because they will
Yeah.
be small.
Exactly. By time, you know, you start with cuboidal, central cuboidal cilia, some few club cells. Then the club cell increase, the cilia cell decrease until it become mainly club cells. Okay?
Are capsules found in alveoli or is that?
No. It's just in the bronchiole.
You must
Okay? Any question till now? So now we are in the second part, which is the respiratory portion. The respiratory portion starts with what? Respiratory bronchiole. Then we have this view. We have this grape-like structure. It's called alveolar sac. Each of these surfaces is known as alveoli. And if I look inside this tube in the center, we name it alveolar duct. So let's start one by one. So this is our slide, by the way, from the lab. What is this? I can see very simply this is a tube. Okay, we have the same layer like the last slide, which is a bronchiole, but we have protrusion from the wall, right? Then I just zoom in here, I just zoom in here. So you can find here what? The same layer like the bronchiole. What is this? We had the simple cuboidal cells. Now the cells, these cells become very less and more club cells. Then what is the second layer?
Smooth muscle.
Muscularis. Do we have cartilage? Do we have gland?
No.
Do we have goblet cells?
No.
No? You have just 3 layers. Then if you find a little bit connective tissue, it will be advantageous. So it has part like the terminal bronchiole. What about this part? It is like the second part, which is the alveoli. I will mention it later. So this is just combination between part of the conducting and part from. So, but you can imagine how it looks like the tube become invaded by some protrusions, which is the alveoli. Clear? Okay, so simply we have 2 parts here. What is the function of the respiratory bronchiole? And both of them, conditioning and gas exchange. And it has 2 parts in the structure. Part like the terminal bronchiole and part like the alveoli. So what is the lining epithelium and the bronchiole?
Cuboid.
Simple cuboidal epithelium with more club cells. Okay, then under the epithelium we have, then we have, what about that outpocketing?
Alveoli
This is
squamous.
the alveoli. What is the lining epithelium of the
Simple
alveoli?
squamous.
2 cells, pneumocyte type 1, pneumocyte type 2. Okay, so this is the respiratory bronchiole. Then another picture here. What is this? I can see a duct which has no wall. It has no wall. Really? Or what? It's made out by, what are these structures? Alveoli. So it's a tube made by alveoli. So there is no wall. It's just alveoli. So if you find it a little bit long, this is alveolar duct. If it looks like a sac, it's called alveolar sac. So each of these circles, if I just go and make a circle here, what is this? This is an alveolus. What about this? It's another alveolus. What about this? It's another alveolus. So if I go to this part, what is this? No, this is a long. So this is a duct. What about this? Duct. What about this? This. This. This is simply what. And what make the wall? In all of them, the alveoli. In all of them, it's made by alveoli. Okay? So we have here alveolar duct, alveolar sac, and alveoli. What is the alveolar duct? It's just an elongated airway made by alveoli. What about the sac? It's a little bit dilated airway made by. That's it.
Doctor,
Yes.
are the alveolar ducts the same as the respiratory bronchioles?
No, we lost the bronchial part.
Okay, we're done.
We are done. Just alveoli now. Only alveoli.
It's what comes before it.
The respiratory is the, yeah, the one before this.
So the duct is made of pneumatocytes?
Of what?
Pneumatocytes?
Of alveoli.
Alveoli are made of.
So like, this is an alveolus, and another one, another one, another one, another
Oh,
one.
okay.
All of them together making the wall, right? If I zoom in one of them, I can see the pneumocytes. Okay, so let's move to one of these alveoli. How many alveolus we have in our
300.
one lung? 300 only?
Too much.
It's
Why?
150 million, around 150 in each lung. Okay, and how big it is? It's around 0.2 millimeters in diameter. Okay. So, and what about? Can you see this? We have a lot of capillaries surrounding each alveolus. A lot of capillaries. A lot. What is the aim of this? What is the function of the alveoli?
Oxygen
Yes,
exchange.
Gas exchange. So why we need a lot of blood vessels? To bring the deoxygenated blood, then it become oxygenated and send it back, right? Or is it opposite?
No.
Okay, so we are bringing it from the pulmonary artery, sending it to the lung, and then take the oxygen and give it the carbon dioxide. So this is simply how we describe the alveoli from far. But let's go to the single epithelium. We have two cells lining the alveoli. The first one is a pink one. Can you see it? This one, the very thin one. This is called pneumocyte type 1. Actually, we find like this cell it constitutes around 40% of the whole lining epithelium of all alveoli, only 40%. But when we look, you will find it covering 95% or around 90% of the whole surface area. Why? Because how does it look like? This is a whole cell, another cell. So like the whole alveolus covered by just by pneumocyte type 1 mostly, and only one from the other type. So this is why we have, although we have 40% from the pink one, which is pneumocyte type 1, but it covers almost all the alveoli. It's very thin and very long. Okay? Yeah, you can describe it as simple squamous epithelium, but in the exam, you have to write the word pneumocyte. Okay? So sometimes they name it alveolar type 1, but it's okay. Both of them are right. From this description, what do you think? What is the function of this cell? Gas exchange. But there is another function that I don't want you to forget.
Pressure.
No.
Air and blood
No.
barrier.
How these cells are connected? The cells are joined together by tight junction. Okay, so whatever will pass from the air to the blood, or from the blood to the air, has to pass through the cell, not between the cells. And we name this structure, or whatever I just described, as air-blood barrier. Okay? So here we have two functions, the gas exchange and the air-blood barrier. This is very important, and we will mention in detail later on. So how it looks like, what is this?
Pneumocyte.
Pneumocyte type 1, pneumocyte type 1, pneumocyte type 1. All of the flat cells are type 1. Good? Clear? So again, it's very thin squamous cell, 40% covering 95%, and don't forget this. It's attached to each other and to the other cells by tight junctions or occluding junctions. Then these cells are not capable for division. So what do you think? How we will renew? Of course, by the other cell. We just have two cells. So the other cell, which is type 2. We don't have Clara cell inside the alveoli. Good? Okay, so this is the first cell. The second cell. Doctor, can you go a little bit? Take some time, or just go. I really don't care, that's you. Just, yeah. Then the second cell. Okay? This is the second cell. If the other one making 40%, So this is what? 60%. And the other one covering 95%. This one cover how much? The rest, 5%. But can we live without this?
No.
Can we live without the other?
No.
They are both vital for our respiration. What is the function of this? Mostly you know from the physiology. This regeneration, but away from the regeneration. This surfactant. You can't forget this. What is the function of the pneumocyte type 2? Surfactant production. What is the surfactant make? Reduce the surface tension to avoid the collapse of the alveoli.
Is it a lipoprotein?
We will mention it later.
Okay.
So this is the second cell. And how this cell will attach to the pneumocyte type 1? It's the same. It's occluding. I didn't write it here, but it's mentioned there. You should understand this. Where I can find it? So simply, if you look here, this is for me. What is this? This is 1 or 2? It's a flat. The type 2, it's cuboidal cell. So it's a little bit protruding and has a rounded nucleus. Let's go a little bit here. What about this one? This is type 2. So, and here also, what about this? Type 2. What about this? So it's a little bit more protruding than the simple flat cell of the pneumocyte type 1. Okay? So again, simply, they are more cuboidal, 5% covering, 60% covering 5%, and what is the function? Reduce surfactant and
Regenerate.
it's a stem cell. For which type of cells?
1 and 2.
Both of them, type 1 and type 2. Good? Clear? Then, what is surfactant? Histologically, the surfactant has a very unique structure that we can see by electron microscope. This, can you see this? What are these structures? No, they are not lines. This is a vesicle that stores the lipoprotein. When the lipoprotein start to accumulate and stored in the cell, it's not just arranged haphazardly. They make layers. We name it lamellae. So this is called lamellar body. And once I see this, immediately I know that this is surfactant. So this is which organ? Lung, immediately. Don't think, once you see this, you don't have this view in any other cell. So once you see the lamellar bodies, this is lung. And which is in the lung? Type 2. Most of them is alveolar. So pneumocyte type 2. And what is inside this lamellar bodies? They are surfactant. So just look here. Really, I will not ask about this, but just to understand. Our surfactant is made out of 3 structures, or 3 things. The first one is phospholipid. Ignore this. We have phospholipid, we have neutral lipid, and we have proteins. We have these 3 structures in all the surfactant. So which one is the biggest? Make the most of. This is phospholipid. This is called what? Dipalmityl phosphatidylcholine. It's DBPC, and you will find the full name in the comments. Okay? I didn't try because I will not ask about this, but you should know. And of course, you will cover it in the biochemistry, maybe molecular. I don't know, but you should cover it somewhere. Physiology, maybe.
Hopefully.
You will. You will. Okay, so this is the major part of the surfactant. We have a lot of proteins which are very important. Why? Because these proteins arrange the surfactant on the surface of the alveoli. This is not important for us now, but just because it's mentioned here. Okay, so this is very important, and this is the main agent which is responsible for what? For reduction of the surface temperature. Okay? So we need the DBPC for the function, the actual function of the surfactant, which is decreasing the surface tension of the alveoli. Is there any other function of the surfactant rather than decrease the surface tension? No?
Clearance.
Clearance, yeah. We are clearing any foreign materials inside the alveoli. So it's a little bit immune function. Good?
Immunity.
A little bit, yeah. Again, how we will release the surfactant? By exocytosis is an active transport. Yes, it's an active transport. And then when it go out, this purple, blue structure, it will go and make a layer over the whole alveolar surface. It's very important to avoid collapse of the alveoli. Good? So this is simply, we need to draw this. We have a problem that you will see by your eyes in pediatrics. In preterm infants, those who are delivered before the full-term pregnancy. What happened? Those when they come out from, after delivery, they can't take the breath. we have to put them immediately in the incubator. Why? Because their lung is not mature enough. What is the word immature here? They do not produce enough surfactant. So they can't take a breath, and once they expire, it will collapse. So we just put them for some time until the lung mature and produce enough surfactant for them to be able to go out in air and take their breath. And we name this neonatal respiratory distress syndrome. It's one of the very common diseases that you will see. Okay? Clear? So, till now, in the respiratory portion, what I covered the respiratory bronchiole. Then we start by the alveolar duct, alveolar sac, and alveoli. What is the lining epithelium of the alveoli? Pneumocyte type 1, pneumocyte type 2. What is the function of pneumocyte type 1?
Gas
Gas exchange and
Blood-air
blood-air barrier or air-blood barrier. What is the pneumocyte type 2 function?
surfactant releasing and
Surfactant production and
type 1 and type 2.
which other cell producing surfactant-like substance? Club cells. Okay, do you remember the other protein produced by the club cells?
CC16.
Okay. Then the macrophage. How many macrophages we have? We have two types. The first one, it's inside the alveolus. So we just name it alveolar macrophage. What is the function of this? It's a very nice cell. It just go inside and just walk and eat whatever we don't want. If we have air, dust in the air, it will eat it. Bacteria will eat it. So this is why we name this cell dust cell. Sometimes with patients with heart failure, we have pulmonary hypertension. So those pulmonary hypertension make what? Make the blood vessels surrounding the alveoli congested with blood. It is under pressure. So they will push the red blood cells in the alveoli. What will happen? The macrophage will move, run, and eat them. So when the cells start to eat the red blood cells, what happens? They start to deposit small staining inside them. And we name these cells, instead of dust cell, heart failure cells. But all of them is just macrophage.
Because they indicate heart failure.
So again, we have the first type of macrophage is the alveolar. Where I can find this? Inside the alveoli. They are not attached to the wall, inside, just in the air. What's happening here? They are just scavenging the surface. Doing what? Eating whatever we don't want. If we find bacteria, it will eat. Dust, it will eat. We name this what?
Dust cell.
Dust cells. If we have some patient have heart failure, what will happen?
Heart
The red
failure.
blood cell we can reach to the alveolar space, so these cells will start to eat the red blood cells and start to deposit the staining or the staining there, and we name them heart failure cells. Okay. Then after it become full, what I should do? These cells will stay forever inside the alveoli. If they stay a lot, after some time, our lung will become filled with macrophage. Do you think this is logic? So what we should do? Macrophage can move, right? We have pseudopodia. They start moving to where?
Tissue?
No. In the normal way, just go back. How it will go? It will go to what? Yeah, it will try to reach to the bronchiole. Once it reaches, what happened? We have cilia. Then it will push them to reach to the pharynx. But what if they are not able to do this? They will simply start moving from inside the alveoli to outside. Outside where? To the connective tissue between the alveoli. So this is an alveolus and this is another alveolus. We name this part interalveolar septum. So they are staying in the septum. This is why we name them septal macrophage. So what is the septal macrophage? They are already alveolar one that move to the interalveolar septum. Simply, that's it. Okay. So how long it will stay? It can stay for life. It will stay there for some good time. So this is the alveolar macrophage. So this is the
If there is not undergo apoptosis,
No. This one that stay there will stay like this. Only the lymphocyte will try to come and surround in this area.
so they do not kill themselves.
No. Actually, these cells are making a very big problem in certain diseases like tuberculosis. What happened? This is not covered at all. The cells will eat the TB. Okay, they are surrounded by immune cell, so we are protected. But once, and they will move and sit in the septum. And then what happened if any of one of the patients become immunocompromised? then the immune system will become less active, then the macrophage will release a TB. So instead of having one problem of, for example, having cancer or something else, it becomes cancer with TB because the macrophage released that. So it's not just, it's a little bit bigger, but I'm just trying to simplify. So we have two types of macrophage, one inside the alveoli, we name it alveolar. One in the septum, we name it septum. Okay? Good? Any question?
It doesn't break down?
No, it will stay for life. It will stay.
Bacteria and stage.
There's no time for this now. We can discuss later. Okay, so between the alveoli we have a septum. We name this septum what? Interalveolar septum. All the day we are breathing. Exhalation, inhalation. So we need which type of fibers in this area?
Elastic.
Elastic fiber. Of course, we have some collagen for to give it strength.
Okay.
Yeah.
The microphage is trying septal recover.
Septum. Yeah. We have it in the alveoli. It's alveolar. In the septum, it's septum. This is very simple, just read it, no problem in this. I want just to explain this. Just think that we don't have this part, okay? We have one bronchiole attached to the alveoli and another bronchiole attached to alveoli, good? If I block here, like some mucus, block this part, and we don't have this, what will happen? This alveolar space will collapse. So this means that if we just have one way to aerate the alveoli, it will be very easy to collapse. But if I block this in the current situation, I block this, no problem at all. This one, the air will go, aerate this part, and then release from this. Okay, so this is very important. What is the important part here? That we have these pores that connect the alveoli together, and we name this pores of Kohn. This is the name of the scientist. So what is the pore of Kohn? They are the area where we connect the alveoli together. Which type of alveoli they are connected? Those who are opening in different bronchioles. Why? Because we are trying to avoid the collapse of these alveolar spaces. Okay? The blood-air barrier. Let's go to the second picture and then return back here. So let's go here. What is this? We have an alveolar space and we have blood vessel. Okay, so the connection or the relation between the alveolar space and the blood vessel, we name this part air-blood barrier. Okay? As you see, we have part which is like this. What is this? I will describe it now as thin air-blood barrier. And we have part like this. It's called thick air-blood barrier. What's the difference between this and this? Let's explain. So in the first part here, can we say the layers that separate the air from the blood? The first layer is the blue structure. What is this? Surfactant. Then we have the pink cell, which is pneumocyte type 1. Then we have the basement membrane of the pneumocyte type 1. Then we have the endothelium and its basement membrane. Right? This is simply what we just see. And this is actually where the gas exchange occurs. But if we have some connective tissue that separates the basement membrane of the endothelium of the pneumocyte type 1 and the basement membrane of the endothelium, it's still part of the air-blood barrier, but it has different function. Okay? So we have two parts. Let's go back a little bit. So here, we have the thin portion in this picture. What we have here, it's a space between the air and the blood. It's made out of how many layers? Let's count. The first one is the gray, the surfactant. Then
Type 1.
the pneumocyte type. Then the endothelium. Okay, so simply here where gas exchange, okay. Clear? But we have another part here where we separate the basement membrane of the pneumocyte type 1 and the basement membrane of the endothelium. What I can find in this picture? Some connective tissue cells. We have macrophage, we have fibroblast. What is the function of this space? It's not gas exchange. Sometimes we have extra fluid. Do you think we should keep it inside the alveoli? No. Where I should put it?
Lymphatic.
Outside. Outside where? In these spaces. So in this space we keep extra fluid that we don't want. We can't keep it inside the alveoli. Otherwise we have a problem. So and then we will keep it in the lung. We can't keep a lot of fluid in the lung. So what I should do? We should send it to the lymphatic vessels. This is simply the second part, which is the thick portion of the air-blood barrier. Clear? Any question? Then the last organ, it's very simple. We have, you remember the pericardium in the heart?
Yes.
We have the pleura in the lung. It's a cavity, sorry, a membrane covering the lung from around the lung from outside and the chest from inside. So we have two layers. The one which covering the lung we name visceral, and the one which is away or covering the chest wall is called parietal. Between them we have what? We have pleural cavity. What's inside? Serous fluid. Which lining epithelium I can find here? The same exactly like pericardium. What is the name? Mesothelium, the same. It's the same like the heart. Mesothelium. So which cells producing the serous fluid in the pleural cavity? That's it. Do you think we have which type of connective tissue in the pleura, which is no? Which type of fibers? Let's make it like this.
Elastic.
A lot of elastic, but also we need some strength, so we have collagen. Okay, so you just mentioned whatever I wrote, by the way. So again, how many layers we have? We have visceral layer and parietal layer. Between them we have pleural cavity. And in the pleural cavity we have serous fluid. What is the lining epithelium? Mesothelium. And the mesothelium is the one which produces the serous fluid. What else we have? We have collagen and we have elastic fibers. Just think about the function. Okay, then again the mesothelium produces the serous fluid. Yeah, this is not histology, but let's go a little bit quick on it. What is the blood supply of the lung?
From all arteries.
We have two. We have pulmonary and we have bronchial. What is the nerve supply of the lung? We have two. Autonomic, sympathetic and parasympathetic. What is the lymphatic vessels of the lung? We have two. So usually it's two. Okay? So pulmonary circulation. Send blood to which part of the lung? Between the alveoli, to the capillaries between alveoli. For what? For gas exchange. But the bronchial circulation supply the bronchi, the bronchiole, whatever else rather than the alveoli. Anything, not the alveoli. For the autonomic nerve, what I want to control by the autonomic nervous system? Muscle, smooth muscle. In which part?
And the bronchi.
In the bronchi, and also in the gland. Where? Not everywhere. Do we have gland in the bronchiole?
No.
So it's not everywhere anymore.
Bronchi.
In the bronchi and up. So we have a few conditions that you should know for the TBL or for the cases. The first one is the bronchial asthma. This is one of the very common diseases that you should know. Mostly you see someone with this condition. Those who can't take their breath, they are wheezing, okay? And histologically, what happened? This is a normal.
No.
And this is the abnormal. What happened? First of all, the yellow layer becomes thickened. So we have a lot of goblet cells. Then we have thickened basement membrane. And the muscle, which is the pink layer, become much thicker here. We have thickened muscle. Okay, you don't know to memorize, by the way, the pathology. I will never ask in detail of the disease, but at least become familiar with the name. Then we have emphysema. What is the meaning emphysema? Destruction of the interalveolar septum. So it looks like we have a bigger space, but actually, no. We are decreasing the surface area of gas exchange. Those people complaining from, they can't take the breath, shortness of breath. And it's very common with smokers, especially if they are smoking from very long time. We have also cystic fibrosis, is one of the genetic disorder that actually I didn't see at all, but I know you can find it somewhere in the clinic. What happened with those patients? Those patients have thick, viscous secretion everywhere. So imagine that in the bronchiole, in the bronchi, the secretion becomes thick and the cilia can't push. This is deadly, like we can't take the breath. And the same happened with the kidney, the secretion there. A lot of problems happen with those patients because they don't have functioning mucociliary SPM. So these just 3 diseases, just familiarize yourself with them, okay? Any question? I know that you have lecture, have exams and have a lot of things, but really, all the lecture are equal in the exam. So deal with them equally, okay?